Assalamualaikum warahmatullahi wabarakatuh to Dr. Hanisah and all fellow classmates. We move on to the next seminar on acute stress disorder, PTSD and adjustment disorder. My part, I will talk on introduction to stress as Dr. Hanisah has said before. Okay, my name is Nordiana binti Nordin and I'm the first presenter for introduction to stress. Okay, I'll talk on the definition, the theory, the stress source, what are the stress source, response to stress, how to identify stress, and stress management. The first one, definition, what is stress? Based on Kaplan and Sadok, stress is defined as a circumstance that disturbs or is likely to disturb the normal physiological or psychological functioning of a person. Basically, it's affect the physiological and psychological functioning. In other articles, it's also said that stress is an emotional, cognitive, behavioral, physiological reaction that a person experiences in response to environmental traits or demands. Other definition from Kaplan, stress is a non-specific bodily response to any demand caused by either pleasant or unpleasant conditions. Okay. So, in 1920s, Walter Cannon he conducted the first systematic study of the relation of stress to disease. So, Walter Cannon he demonstrated that when stress occurs, there will be stimulation of autonomic nervous system, particularly the sympathetic nervous system, in which there will be fight or flight response. Fight or flight response here are characterized as hypertension, tachycardia, and increased cardiac output. After sometimes, if this fight or flight response has reached its limit, that stress can result to a disease. For example, a cardiovascular disease. Then, in 1950s, Harold Wolff observed that the physiology of gastrointestinal tract appeared to correlate with a specific emotional stress. For example, he said that there will be hypofunction of GI when sadness, and there will be hyperfunction of GI when hostility. Earlier, William Beaumont said that an American military surgeon he had a patient named Alexis Saint Martin who became famous because of a gunshot wound that resulted in a permanent gastric fistula. He noted that during highly charged emotional stress, the mucosa could become either hyperemic or blanched, indicating that the blood flow to the stomach was influenced by emotions. These are the theory or the history of how they demonstrate stress one time ago. So, in 1907 to 1982, general adaptation syndrome. This is a model of coined by Hanselye. Okay, he developed this model, general adaptation syndrome, consists of three stage. The first stage, the alarm stage, which where there's occur. Exhaustion states occur when the person they are divided into two, whether internal stress or external stress. For internal stressors, there are personality, negative thinking, and biological stress. If external stressors, there are physical surroundings, social stress, or any important events or any organization. For example, I took this from Stress Management Ministry of Health Malaysia. Internal and external stressors in terms of personality. For example, cluster A and cluster B personality disorder personality are more common to get stressed easily. Then the negative thinking, contohnya jealousy, being intimidated, narrow-minded, and biological stressors such as being sick, yeah. In terms of external stress, physical surrounding includes gangguan bunyi, bau dan lain-lain. Social stressors includes interpersonal relationship conflict. For examples of important events such as marriage or divorce or any loose kematian can also induce stressors, or any organization in terms of time and workload. So, how do we respond to stress? Our body responds to stress in terms of three system: neurotransmitter response, endocrine response, and immune response. For neurotransmitter response, when stress occur, when we get stressed, the body will activate noradrenergic systems and release catecholamines. Our body will also activate serotonergic systems and increase serotonin turnover. But with increased serotonin turnover means the patient cannot get stressed because stress means low serotonin. So how stress can lead to depression? This is because um, recent evidence suggests that although glucocorticoids tend to enhance overall serotonin functioning, differences may exist in glucocorticoid regulation of serotonin receptor subtypes. For example, glucocorticoid can increase serotonin 5-hydroxytryptamine mediated action. Thus, increase in serotonin 5-hydroxytryptamine mediated action will be increase and intensifies action of this receptor, which have been implicated in the pathophysiology of major depressive disorder. So increase glucocorticoids to serotonin 5-hydroxytryptamine receptor will increase depression. Okay. Next is endocrine response. So in response to stress, the hypothalamus will release corticotropin releasing hormone, and corticotropin releasing hormone CRH will induce the anterior pituitary to release ACTH. ACTH will release and adrenal gland will be stimulated. So there will be release of glucocorticoids and catecholamines. The glucocorticoids or the cortisols increase in abundance and cause multiple actions of the body. It can be sum up as the glucocorticoids action to promote energy use. For example, increase in glucocorticoids it will be increase in gluconeogenesis, increase lipolysis, and increase proteolysis. So will be increase in energy use. There will also increase in cardiovascular activity, especially in fight and flight response. Other than this, glucocorticoids can inhibit functions such as growth, reproduction, and immune system. From this picture, you can see the actions of glucocorticoids here: increase in energy production, increase cardiovascular tone. However, there will be inhibition of growth and reproduction, increase depression and anxiety. There will be inhibit the immune system and inflammation. In terms of immune response, okay, part of the stress response consists of the inhibition of immune by the glucocorticoids. As I said before, glucocorticoids can inhibit immune system. But conversely, stress can also cause immune activation through a variety of pathway, including the norepinephrine production. So what happened? The CRF will release more and more norepinephrine, whether centrally or peripherally, and these norepinephrine neurons may synapse on immune target cells directly. The norepinephrine that release will synapse on immune target cells directly. Thus, in the face of stressors, when stress occurs, profound immune activation also occurs, including release of humoral immune factors such as cytokines, such as IL-1 and IL-6, interleukin-1, interleukin-6. These cytokines can cause further release of CRF and increase glucocorticoid effects. Therefore, increase glucocorticoids increase inhibition of immune inhibition. Okay, next I will move on to stress identification. Four parts. There will be four parts: the cognitive, emotional, physical, and behavioral. Okay. In terms of cognitive symptoms, there will be constant worrying, the racing thoughts, forgetfulness and disorganization, inability to focus or concentrate. There will be poor judgment and being pessimistic or seeing only the negative side. In terms of emotional symptoms, a person can be easily agitated, frustrated, and moody, feeling overwhelmed like you are losing control or need to take control, difficulty relaxing or quieting your mind, feeling bad about yourself means that the patient has low self-esteem, feeling lonely, worthless, and depressed, and trying to avoid others. In terms of physical symptoms, a patient may experience low energy or fatigue, headache, upset stomach, um, aches, pain or tense muscles, chest pain and rapid heart rate, insomnia, frequent cold and infections because of reduced immune systems, inhibit immune systems, loss of sexual desire, nervousness and shaking, ringing in the ear, cold or sweaty hands and feet. The patient may also complain of dry mouth or difficulty in swallowing, and also clenched jaw or grinding teeth. In terms of behavioral symptoms, there will be change in appetite, whether increased appetite or loss of appetite, procrastinating or avoiding responsibilities, increased usage of substance in order to displace his mood, exhibiting nervous behavior such as nail biting, fidgeting with restlessness and pacing, compulsive, and also smoking. Okay. Now we have reached to the stress management. Stress management I divided into two: short-term stress management and long-term stress management. In Malay, as described in stress management in Ministry of Health guidelines, for short-term stress management there are 10 Bs. Bertenang, bernafas dengan dalam, berkata relaxlah, beribadat, bercakap dengan seseorang, berurut, berehat dan mendengar muzik, beriadah, bersenam dan berfikiran positif. So in English, to keep calm, deep breathing, relax, to worship, to talk to someone, massage, rest and listening to music, recreation, do some exercise and to positive thinking. In terms of long-term stress management, the mnemonics is ideal. Ideal, I to identify what is the main problem, what is the main cause for for the stress. D is to describe and to find out what are the ways to get out of the situation, to get out of the stress situation, and then evaluate whether the ways, the problem solving techniques, the pros and cons. Evaluate the pros and cons uh, of the management, the suggestion to get out of the stress. A is to act in the right way. L to learn from mistakes, learn from the experience, how to manage the stress. Next, this one, these are the skills that we can earn to manage our stress. There are 6: anger management skills, positive thinking skills, time management skills, problem solving and decision making skills, relaxation technique, and assertiveness. Doctor, do I need to explain all this?
Okey lah, tak payahlah you may skip.
Okay. That's all for my side.
Okay, thank you very much. Ada soalan tak? You all dah expert semua dah 24, 25 tahun. So semua dah expert to stress, to manage stress, own stress. But what we are focusing today is major stressors kan, because just now the introduction is normal usual stresses that we tend to manage and cope daily kan, but when it comes to post PTSD, post traumatic stress or acute stress, meaning that the amount of the stress too is too big kan, or too great kan. So make it your coping and your defense mechanism and your psychological resources not able to probably cope with the amount of stress that occur suddenly, and therefore the patient tend to develop the disorder kan. Alright, so if kalau tak ada soalan, then we can continue with the next part of the presentation lah. Siapa yang present ni?
Saya Prof.
Okay.
Okay,
Syazwan.
okay. So my name is Shazwani and I will proceed with the next part of our presentation, which is acute stress disorder and also post-traumatic stress disorder. Okay, next. Okay, so this is the outline of my presentation. Okay, so the definition of stress-related disorder, it is a mental disorder marked by increased stress and anxiety following exposure to a traumatic or stressful event. And it can occur from single traumatic event or from prolonged exposure to trauma, for example, like physical or sexual abuse. And then the person will react to the experience with fear and helplessness, persistently relive the event through dreams or flashback, and they will try to avoid being reminded of it. For example, like they become a victim of crime, diagnosed with life-threatening illness, or experience physical or sexual abuse. Okay, before we go further, let us see first what is the difference between post-traumatic stress disorder and also acute stress disorder. So both are fall under trauma and stress-related disorder, and both will share similar signs and symptoms. However, in PTSD, the symptom will occur more than 1 month after exposure, and then usually the symptom develop sometime delay after the trauma. The symptom can develop as early as 1 week or may develop later, for example, like 30 years later after the trauma. Compared to acute stress disorder, the symptom must last within 3 days to 1 month, and the symptom typically will peak in days or weeks after the trauma, and then they will gradually decrease over time. And then when you want to diagnose PTSD, you must have symptom from each group. However, in acute stress disorder, you can combine the symptom. And then PTSD, it can be a continuation of acute stress disorder if there is an absence of appropriate treatment. Okay, next. Okay, so in terms of in epidemiology, so the prevalence of stress-related disorder occur about 8% in general population, in which the woman has higher prevalence than men, and it can occur in any age, but most prevalent in young adult because at this age they are exposed to more stressor than other the other age group. And then the prevalence is higher if the individual is single, divorced, widowed, socially withdrawn, and has low socio-economic level. And then also it is high. The prevalence is higher if there is a family history of depression, especially in first degree relative. And then also, two-thirds of PTSD patient has associated with other psychiatric illness such as depressive disorder, bipolar, and also substance-related disorder. Next. Okay, for etiology, we can identify the causes. The first one is stressor, second is risk factor, biological, psychodynamic, and also cognitive behavioral factor. So I will explain one by one. So the first one is stressor. So stressor is basically the causative factor of the stress-related disorder itself. And then we need to understand that not all people will develop disorder after they expose to the stressor, because it will depend on the on the type of stressor itself, and also it will depend on the biological and also the psychosocial background of the patient. Next. And then second one is risk factor. So as I mentioned just now, not all people will develop into disorder. So if the patient has this risk factor, so they are predisposed to develop it. So the first one is female. Second is when there is a history of childhood trauma, when they have genetic vulnerability to psychiatric illness, when they have premorbid personality like borderline personality, paranoid, and also dependent. And then when they face recent stressful life changes, recent excessive alcohol intake, and also when they have poor family support. And then the last one is when they have a perception of external locus of control rather than internal one. Okay, so before that, locus of control means that how strongly the person believes that he or she has control over the situation and experience that will affect their life. Okay, internal locus of control means that the patient believes that the event occurred in their life is because of their own action. Okay. External locus means that the patient believe that the events is occurred due to external factor. So in patient with external locus of control, which means that they believe everything is because of external factor. So when trauma happen to them, so this will intensify the perception itself, which means that patient will become more fear, more anxious, and more anxious to face the world because they believe that this because they believe that the external factor that causing the trauma itself. So this patient will predispose to PTSD later. Okay, next. Okay, under biological factor, we have several causes. The first one is structural changes of the brain, increased noradrenergic system, hyperregulation of opioid, and also HPA axis dysfunction. Okay, under structural brain changes, they found out that patients who develop stress-related disorder, they have a decreased volume in hippocampus, left amygdala, and also in anterior cingulate cortex, which is the main part that control our emotion and also the one that control our emotion and also our fear. Okay, and then they also found out that they have a lower white matter integrity in the brain. So in this picture, we can see the changes that occur in patient with stress-related disorder. For example, in the hippocampus, we can see in PTSD there will be an increased responsiveness to the traumatic and also emotional, and also in other brain parts. So you can read that later. Okay, next slide. Okay, second is the HPA axis dysfunction. So as we know, when we stress, our endocrine will release cortisol so that to cope with the stress. They found out that they have a low level of cortisol at the time of trauma. So this will make the HPA axis to work more stronger and prolong in order to increase the cortisol level so that the patient to make the patient can cope with the stress. So when this happens, so it will lead the patient to develop PTSD. And then they found out that one study in which the urinary cortisol level obtained upon admission to hospital in MVS survivor was significantly lower among subjects who were found to have PTSD 1 month after trauma than among the patient who didn't develop PTSD. Okay, next. The third causes is the increase in noradrenergic system, in which after traumatic exposure, there will be activation of HPA axis and also sympathetic nervous system. So patient will exhibit sympathetic nervous system manifestations such as increased exhibit nervousness, increased blood. And one study found out that there is an increased urine catecholamine concentration in sexually abused girls. And then the fourth one is opioid system, in which there is a hyperregulation of opioid system, which mediate anxiety-like behavior. So the evidence is that one study showed that when they give opioid receptor antagonist to a combat veteran that developed PTSD, so the symptom has improved. Next is psychodynamic factor, in which the trauma has reactivated a previously present yet unresolved psychological conflict. So the revival of the childhood trauma result in regression and the use of defense mechanism of repression, denial, reaction formation, and undoing. So this is the psychodynamic theme in PTSD. So you can read later. And then last etiology is the cognitive behavioral factor, in which in stress related disorder there are two phases that how they develop stress related disorder. The first one is classic conditioning, in which the trauma, which is the unconditioned stimulus that produce a fear response, is paired through classic conditioning with a conditioned stimulus, which is a physical or mental reminder of the trauma, such as the sight, smell, or the sound. And then the conditioned stimuli, which is the sight, smell, or sound, elicit the fear response independent of the original unconditioned stimulus, which is the trauma. So later, the person will develop a pattern of avoiding both conditioned stimulus and unconditioned stimulus. Next. Okay, then the clinical features. There are three dominant symptoms in patient with stress-related disorder. The first one is intrusion. Okay, patient will have flashback, distressing recollection of dreams, physiological or psychological stress reaction to exposure to stimuli that are linked to the trauma. Patient also will exhibit avoiding behavior, uh, such as they will have effort to avoid thoughts or activities related to the trauma. They will have anhedonia, reduced capacity to remember events related to the trauma. They also will have blunted effect, feeling of detachment or derealization, and a sense of foreshadowed future. Other than that, they will also has manifestation of increase in automatic arousal, such as insomnia, irritability, hypervigilance, and also exaggerated subtle. Next, okay, to diagnose post-traumatic stress disorder, so these are the criteria that we need. Before that, this criteria is applied to children more than 6 years old, adolescents, and adults. Okay, so the first one, we need to have exposure to actual or threatened death, serious injury, or sexual violence. Second, for the symptom, okay, there must be at least one or two symptom from each group. So which means that the person must have the symptom from the presence of intrusion, persistent avoidance of stimuli, negative alternation in cognition and mood, and also marked alteration in arousal and activity. And then the disturbance must uh, must be more than 1 month, which cause significant distress or impairment, and it is not due to substance or medical condition. And then after that, we need to specify whether the patient has dissociative symptom, which is depersonalization or derealization, or with delayed expression, in which the full diagnostic criteria are not met until at least 6 months after the event. Next. Okay, so this is just similar. They just combine the persistent avoidance of stimuli and negative alteration in cognition and mood. Next. Okay, and then for the diagnosis of acute stress disorder, the definition is similar, which is exposure to acute or threatened death, serious injury, or sexual violation. However, in symptoms, they just combine all the symptoms from the group previously, in which there must be at least 9 symptoms from any intrusion, negative mood, dissociation, avoidance, and also arousal. And then the duration must be within 3 days up to 1 month only after the trauma exposure. And then it is not due, it causes disturbance and impairment to the patient's life, and also not attributable to substance or medical condition. Next. Okay, so these are the differential diagnosis that we can think of when we make this patient, such as panic disorder, general anxiety disorder, MDD, borderline personality disorder, dissociative disorder, factitious, and also adjustment disorder. And also we need to rule out whether it is a medical or substance-related causes, especially epilepsy and also alcohol abuse. Next. Okay, in terms of course, usually stress-related disorder usually the symptom will develop sometime after the trauma, and as I said just now, the delay can be as short as 1 week or as long as 30 years, and then the symptom also can fluctuate over time and may be most intense during the period of stress. In untreated population, in untreated population, 30% of them will recover completely, 40% will continue to have mild symptom, 20% will have moderate symptom, and 10% will remain unchanged and become worse. Okay, in treated patient, about 50% of them will recover after 1 year. Okay, so this is the indicator of good and poor prognosis. So it will be a good prognosis if it is a rapid onset of symptom, short duration of symptom, and then patient has good premorbid function, has strong social support, and also in the absence of other psychiatric illness. Okay, and the poor prognosis is just the opposite of good prognosis. Okay, next. Okay, before that, in terms of investigation, in stress-related disorder, there is no specific investigation to diagnose it, and there is also no questionnaire. There is no questionnaire such as in anxiety disorder or in major depressive disorder. So we just go to the management first. Okay, so in management for patient with stress-related disorder, first thing we need to decide whether we want to treat this patient as inpatient or outpatient. We need to admit the patient when the symptoms are severe or when there is a risk of suicide or other violence exists. And then our main treatment is psychotherapy with or without pharmacotherapy. And then our major approach in PTSD is to support, encourage to discuss the event and also give education about the coping mechanism. And then when patient has experienced a traumatic event in the past and now develop PTSD, our emphasis should be on education about the disorder itself and also its treatment. And we need to give pharmacological treatment if we also need to give pharmacological treatment to the patient. Okay, next. So these are the medication that we can give to the patient. So we can give antidepressants such as SSRI, TCA, and also monoamine oxidase inhibitor. We also can give anticonvulsant, adrenergic antagonists to relieve the hyperarousal symptom. And then if patient develop aggression or agitation, we can offer antipsychotics such as haloperidol. And if patient has a problem with sleep, so we can give hypnotic agent. Next, okay, for psychotherapy, so in PTSD, it is a trauma-focused psychotherapy in which our aim is to improve the symptom, quality of life, and also restore their self-esteem. And we also will teach them coping skill. So there are few types of psychotherapy, and the main psychotherapy that we give is the cognitive behavioral therapy, in which under it we have exposure therapy and also cognitive restructuring. And then second therapy is eye movement desensitization and reprocessing. And other therapies such as psychodynamic psychotherapy, talk therapy, hypnosis, social support group, and also family therapy. Okay. Next. Okay, so I will talk about the cognitive behavioral therapy. The first one is exposure therapy. So in exposure therapy, what we do is that the therapist will help the patient to confront their traumatic memory through methods such as writing or verbal narrative about the traumatic experience. And then they also will gradually expose the patient to the traumatic experience or stimuli, but in a safe way. Okay, the aim of exposure therapy is we want to help the patient to cope with their fear and to elevate the symptom. For example, in a patient after motor vehicle accident, so the first step that we can do to confront their fear is that we ask them to talk about the traumatic event itself, and then after that, when they are okay, we move to the next level, such as we ask them to sit in a car. And then after that, we move to the next level again, like we bring the patient to the side of MVA itself, so that they will slowly confront the fear, okay, and also the trauma. Okay, and then the second one is cognitive restructuring, in which we help the patient to identify and challenge the inaccurate or unhelpful cognition and replace them with realistic and helpful ones. Because patient may feel guilt or shame about something that is not their fault. So the therapist here will help them to look at what happened in a realistic way. And then we also will do stress management such as relaxation technique and cognitive approach to cope with stress. So the third therapy is eye movement desensitization and reprocessing, the EMDR. So it is a evidence-based therapy. So in EMDR, what we do is that the therapist will ask the patient to talk about the disturbing traumatic memory. While the patient is talking about the memory, the therapist will do hand movement, and the patient must follow the hands movement. Okay, they believe that by doing so, the patient's brain need to process lots of information at the same time, and then when the brain need to process lots of information, so the traumatic memory will slowly become faded and lost its emotional charge. Okay, so this will elevate patient's emotion and also make patient feel worthwhile, less anxious and depressed because the intrusive memory already faded, already become faded. Okay, so, so I think that's all from my part. So any question?
Any question to our presenter?
I have a question.
Oh,
For just now you mentioned about the difference between acute stress disorder and also post-traumatic stress disorder. For ASD, you don't have to have different for the diagnosis. You don't have to have different domains, and as compared for PTSD, you have to have all the domains has to be fulfilled. I just want to ask why is it like that?
Why like that? I'm not sure. I'm not sure, Doctor.
can you repeat again your question?
The different in PTSD we have to fulfill all the domains from the three different domains just now Shazwan you mentioned intrusion, avoiding, and also increased automatic arousal as compared in acute stress disorder. You have to have 9 symptoms, but it doesn't matter. I mean, it does not necessarily have to fulfill all three domains. So I was just wondering why. Is there like a reason for that, or
Acute stress berapa lama? The onset of the symptom after the trauma experience as opposed to PTSD, berapa lama the illness on? Kalau you nak kata acute stress maksudnya berapa lama baru the trauma happen?
3 days to 1 month acute stress, PTSD?
Yes, right. So of course, obviously, there has been no organization yet as what the symptoms that the patient will experience. Kan? So still jumble up. Maknanya all the fight and flight response that one can have following a trauma is will be there in a stress. For example, you just imagine a rape victim ke apa. So it's still very much hypersensitive, fight and flight response is not yet organized. But in PTSD, maksudnya dah after sometimes, kan, after 1 month. So acute stress, if the patient does not cope well with the trauma, and then it will end up developing into PTSD lah, kan. So first dia akan develop acute stress disorder, kan, following certain trauma, patient acute stress disorder, all those symptoms lah that tak categorize into intrusive symptom, whatever lah, so long that you diagnose acute stress disorder, kan, provided there must be a trauma there lah, kan, maksudnya betul ada traumatic event occurring before the symptom started. And then normally kalau normal people they get to reorganize their mind, kan? They start to cope, and then somehow after 1 month the symptom will slowly subsided, kan? Will improve. But to some patient, they cannot cope with the trauma tadi, and they end up develop post-traumatic stress disorder. That is when the symptom persists longer than 1 month lah. Alright, so that is when kalau symptom dia persistent, that is when you diagnose as PTSD lah. Okay, so there is not much different except for the duration, itu je. And then of course sebab PTSD, they get more structured lah sebab dah ada duration dia, kan? Okay. But both need to have trauma happening lah. Tak boleh tak ada trauma tapi nak diagnose PTSD. Okay, so what group of patient yang more susceptible or more prone to develop PTSD and acute stress ni? Etiological tadi, psychosocial etiology. Those people with underlying personality disorder lah, kan? Because you know that when the patient having a disordered personality, meaning that their coping skills are non-adaptive, kan? Because they have disordered personality, normally their coping skill is non-adaptive coping lah. So that's why make them vulnerable to develop PTSD as well as ASD lah, kan? So especially cluster B, kan? They are very disorganized kind of people, kan? So that make them more prone to develop PTSD. Alright. Okay, ada soalan lain lagi? Management, how do you manage people with PTSD? You bagi ubat tak?
We give medication only if patient develop the symptom, for example like depression. So we give antidepressant, and if patient has insomnia, so we can give hypnotic agent to the patient.
What is the mainstay treatment of PTSD? Is it because patient have comorbid depression je you bagi ubat? Kalau PTSD itself, PTSD per se, what is the mainstay treatment?
The mainstay treatment will be psychotherapy.
How about pharmacotherapy? You can give your SSRI lah, kan? Mainstay treatment would be SSRI or SNRI, your antidepressant. It's not that you give them only when they have comorbid depression. It's the treatment for the PTSD itself. But of course, you need to supplement them with psychotherapy lah, kan? Yang you cakap tadi, trauma work, trauma focus psychotherapy, you work along the trauma, kan? Or the one that you mentioned, the EMDR, and then CBT, okay, some form of supportive psychotherapy. Alright. But you may use SSRI, SNRI, or even benzodiazepine lah, kan? Benzodiazepine. Alright. Ada soalan lain? Tak ada soalan dah, clear dah.
Doktor,
Yeah.
I have a question.
Uh-huh.
So those yang dah been diagnosed with acute stress disorder, if the symptom persists until after more than 1 month, so the diagnosis will be changed to PTSD.
Yes, correct.
Okay.
So long that memang dia experience trauma lah, kan? Nak diagnose ASD tu pun dah kena ada trauma. Because normally kalau you all ni suka diagnose, patient datang emergency overdose paracetamol, baru break off dengan boyfriend, and then you put acute stress disorder. Memanglah stres putus cinta kan, tapi it doesn't warrant the diagnosis of that severe trauma lah, okay, to be considered as acute stress disorder, right? So normally major trauma, alright. Okay, ada soalan lain?
Assalamualaikum warahmatullahi wabarakatuh, Dr. Hanisah.
Alright.
Dr. saya nak tanya pasal tadi malingering kan.
Dah tukar dah, terlepas dah.
Dah terlepas tadi.
Apa dia?
Doktor, yang pasal ada ke label indifference dalam malingering kan, Doktor?
Apa dia dalam?
Malingering.
Aha.
Apa nama dia? Label indifference ada.
Label indifference is the term we quote for conversion disorder, not for malingering.
Sajalah.
Conversion. Apa maksud dia label indifference?
From what I understand, the patient does not pay attention to the disease. Something.
Yeah. Yes. So for example, patient was referred to you because dia ada hemiparesis, kan, weakness of limbs ke, for example. But when you got to talk to the patient, they wouldn't be having much concern about the difficulty or the physical disability that they are having, but they'll be more concerned talking about their psychosocial issues or problems that they are having. Kan, kalau patient yang betul-betul physical punya condition, they will be worried about the handicap that they are having lah, kan, the weakness, the inability to walk. So this term you see in conversion patient, label indifference. Maksudnya bila dia cerita pasal you, they wouldn't appear to you as if they bothered so much about the physical handicap or disability that they are having. Okay. So malingering tak ada term apa-apa lah. Malingering, all you need to do is to establish the secondary gain. Itu je, kan. So kena work out on the psychosocial background lah. What would be the gain that the patient may be having by adopting to have certain illness, kan? Alright. Ada soalan regarding the acute stress and the PTSD ni before we move on to the adjustment, kan? Tak ada soalan. So it's not only that we are referring patient to have PTSD following natural disasters, kan? Quite often that you see the diagnosis being missed among your medical and surgical patient, kan? Your patient yang masuk medical ward diagnosed with terminally ill cancer, kan, stage 4 cancer. So sometimes apart from telling them about their cancer diagnosis, you should be put more observation into diagnosis of PTSD, kan? Sometimes patient takut nak datang hospital sebab dia dah develop PTSD features, kan? Bau ubat je dah avoidant behavior, bunyi ambulans je dah tak nak datang. It's part of the hypervigilance symptom, part of avoidant behavior, kan? Undergoing traumatic invasive investigative procedure itself for a patient sometimes can be very traumatizing, kan? So PTSD can happen among your patient in medical or surgical ward nanti, kan? So be sure that you look into the psychosocial component of them, kan? Especially yang dapat diagnosis teruk-teruk tu, kan? Of course, kalau you kerja kat emergency, trauma patient, your orthopedic patient, kan, following the fracture, amputation, sometimes they may develop PTSD symptom following motor vehicle accident. Cuma bila you all tengok patah ni, you just focus dekat tulang lah, but you forget to ask about the post-traumatic stress symptom. Alright. Okay. Okay lah. We move on with our next presenter kan, adjustment. Okay.
Okay, thank you, Doctor.
Assalamualaikum warahmatullahi wabarakatuh. So actually before we go to the adjustment disorder, we first go to the reactive attachment disorder and also disinhibited social engagement disorder.
Okay.
Just briefly, so these two disorders is included because it is related to stress and also trauma in childhood. So keep in mind that these two disorder is actually rare and only diagnosed in childhood. Next. So this is my outline. Okay, so first we go to the attachment theory. So in the attachment theory, these three important factors are interrelated, where the child need effective relationship with the primary caregiver, which is usually the parents, and what they need from their primary caregiver is actually protection, nurturance, and comfort. So there's been an observation done by Mary Ainsworth and her colleagues, where it's known as strange situation procedure. They have come up with three patterns of attachment, which is the first one is secure attachment. It resulted from when the child experienced that the caregivers are emotionally available. So it caused the child to become more exploratory and more well adjusted. The second one is insecure attachment. It occurs due to the child perceive that the parents, the caregivers is not constantly available. And the third one is disorganized attachment, where the child actually need proximity from the caregiver. However, they fear that something bad will happen if they approach their caregiver. Okay, next. So it is these two conditions is hypothesized to be due to grossly negligent parenting and maltreatment, causing the disruption in the development of normal attachment behavior, causing the aberrant social behaviors in a young child. So it results in either reactive attachment disorder or disinhibited social engagement disorder. Okay, so a little bit on epidemiology. So it is, as I've mentioned, it is a rare condition occurring in less than 1% of the population. However, studies in high-risk population shows more percentage of having this inhibited social engagement disorder rather than reactive attachment disorder. Okay, so for the etiology, the first one could be because of the maltreatment by their caregivers, could be due to emotional neglect or abuse, either emotionally, physically, or sexually. The second one could be because of compromised parental ability, could be due to parental psychiatric disorder, substance abuse, patient-owned upbringing, and also premature parenthood, where this caused the parent to neglect their child. And the third one could be because of frequent changes of primary caregiver. So little bit on clinical features. So it is usually identified by preschool teacher or pediatrician based on direct observation of the child. So in infants, usually they will be presented with non-organic failure to thrive, weight below third centile, malnourished, and socially there are little spontaneous activity and marked diminution of both initiative towards others. Okay, so there could also be psychosocial dwarfism, where it manifested in children between 2 to 3 years old. So it is due to unfriendly caregiver-child relationship. So the child will present as short and have frequent growth hormone abnormalities. So next is DSM-5 criteria for reactive attachment disorder. So for the first one, for the criteria A, it is a consistent pattern of inhibited, emotionally withdrawn behavior towards adult caregiver, and have to have both of the following, where they rarely or minimally seek comfort and also rarely or minimally respond to comfort. The second one is there is persistent social and emotional disturbance and two of the following: minimal social and emotional responsive, limited positive effect, and also episode of unexplained irritability, sadness, or fearfulness. So criteria C, The child has experienced a pattern of extreme of insufficient care, at least one of the following. There is either social neglect or deprivation, either there is or repeated changes of primary caregivers, or unusual setting. So the criterion C is considered to be responsible, causing the criterion A, and also does not meet autism spectrum disorder. For criteria F, it must have to evident before age of 5 years, and the child has to have a developmental age of at least 9 months. Okay, next. Okay, next is diagnostic criteria for this inhibited social engagement disorder. So actually, it's quite the same with reactive attachment disorder. However, in criteria A for this inhibited social engagement disorder, it is a pattern of behavior in which a child actively approach and interact with unfamiliar adults and exhibit at least two of the following, where they have reduced or absent reticence in approaching and interacting with unfamiliar adults. They could have overly familiar verbal or physical behavior, diminished or absent checking back with adult caregiver, and also willingness to go off with an unfamiliar adult with minimal or no hesitation. And others is quite the same. Okay, next. Okay, so this is just the table of difference between the reactive attachment disorder and the social engagement disorder. So actually, the reactive attachment disorder is quite resemblant with the internalizing disorder, where the child themselves keep their emotion and also their problems inside. Whereas in inhibited social engagement disorder, they tend to manifested it outside and show it in their own behavior. Okay, next. So differential diagnosis could be autism spectrum disorder, could also be ADHD, PTSD, language disorder or delay, and also intellectual disability. Okay, so for the cause and prognosis, so usually the children with reactive attachment disorder, when they are adopted into a caring environment, they improve in their attachment behavior and may normalize over time compared to disinhibited social engagement disorder, where they have difficulty in developing attachment to new caregivers. So it basically depends on the duration of neglect, severity of neglect, degree of impairment, and also constitutional and nutritional factors. Next is for the management. So first, before we start to treat the patient, we need to know the child's safety. So we need to assess the level of safety and adequacy of caregiving. If there is evidence of any neglect or abuse, we should report to any law enforcement or child protective service. And if there is evidence of maltreatment and malnourishment, so hospitalization is necessary to treat the patient. And for the last part is for the management. So for biological management, is to assess and treat for malnourishment, and psychotropic medication is only given if there is to treat any comorbid. For example, such as if the patient have ADHD overlap with the condition disorder, so we can give stimulants such as Concerta or Ritalin. Okay, next is psychological. This mainstay for the is the most important management for this kind of disorder. So at risk caregivers, we can give and nurturing interaction. Also, we can do psychotherapeutic modalities, psychotherapy, and also educational counseling service. And lastly, for social, we can give psychosocial support service and also close monitoring of progression of the patient. So that's all from me.
Any question regarding reactive attachment and this inhibited social engagement? Clear? This is for the child lah, okay? Dulu tak ada DSM-4, but they incorporate this into DSM-5 lah, because this is a pattern of post-trauma among children, okay? If you used to do a lot of field work kan, jumpa budak-budak yang duduk tepi jalan, tak ada rumah kan, yang no parent, anak gelandangan, then you can quite often see this pattern of disorders, okay? Ada soalan? Tak ada. Okay.
Doktor, I
Yeah.
want to ask, but it's regarding PTSD just now.
Okay.
PTSD can present later, and for example, like 30 years later after the trauma. Actually, I don't really get it, how it can present later.
Kenapa? Why do you think that following the immediately after the trauma, patient doesn't actually exhibit the symptoms? Some of them will remain dormant, kan, quiescent, especially if the trauma happened during childhood, kan? Kenapa? What do you think happened? How do you cope with the trauma? What resources that you have? Tak baca ni, defense mechanism, your defense mechanism, kan? Kalau your physical stressor tadi, your apa ni, your inflammatory response semua, kan? Your bodily reaction, your HPA Axis, kan? All those will come into play to help you fight the physical stressor. But when it happened that the patient had psychological stressor, trauma, so obviously your defense mechanism will come into play lah, kan? So if let's say the trauma happened during childhood, kan? So childhood years, those are the very crucial period, most vulnerable period. And the child is really malleable. They are very, because they are like plain cloth, kan? Because they are very adaptive, kan? So normally they tend to repress your defense mechanism, kan? Repression, denial, suppression, or even dissociation. All those defense will come into place, right? So that's why kalau you tanya the victim of child abuse, for example, they can hardly recall whatever the trauma that they experienced during childhood, kan? If they happen to have some memory, it's going to be very patchy memory, a very patchy one, because it's too hurtful for them to memorize, kan? So normally it is buried deep inside their mind until later on when they achieve adulthood, kan? So sometimes the relationship, the romantic relationship, the new trigger, the new situation will sort of trigger the suppressed memory tadi, kan? The repressed memory tadi. So that is when the patient will start to re-experience all the symptom following the trauma, kan? So that's why you tengok nanti late adolescent, early adulthood, waktu tu baru dia datang. Difficulty sleeping, irritability, nightmare, semua-semua, kan? And then when you ask, okay, masa kecil dulu, they have experienced trauma, kan? So most of the cluster B disorder, personality disorder, they are a result of childhood abuse, kan? The fact that your patient develop borderline personality, they develop narcissistic personality, antisocial personality, most of them comes from the disordered upbringing, kan? Trauma during childhood. So that's why they end up developing a disordered personality, kan? So that is your defense mechanism lah. So masa kecil you tak rasa, tak develop all those PTSD symptom, but later part then some situation will trigger the symptom. Okay. Alright.
Okay, thank you, Doctor.
Alright. Boleh sambung adjustment.
Alright. Okay, Assalamualaikum.
Salam.
Okay, so I'm gonna continue with adjustment disorder. So this is my table of contents. So I'm gonna look at the definition and then etiology, epidemiology, diagnosis, and management. So, okay, definition of adjustment disorder. So it's characterized by an emotional response to a stressful event. So the stressors could be financial issues, medical illness, relationship problems, and the symptoms must begin within 3 months of the stressors. So based on DSM-5 definition, a condition adjustment disorder is a condition, condition in which people develop symptoms of emotional distress or behavioral symptoms in response to the stressful events or feel overwhelmed by their circumstances. But the symptoms fail to meet the criteria for a more specific diagnosis, such as acute stress disorder or PTSD. Okay, so based on DSM-5, the emotional distress or behavioral symptoms are experienced can be varied symptoms, so it ranging from depression to anxiety to impair in work ability or function. So the stressful event could be single, meaning like a divorce or a loss of a job, or multiple, meaning like a death of a person, which coincides with patient's physical illness and loss of job. Or it could be also recurrent and continuous. Recurrent, such as example, seasonal business difficulty, meaning like we'll have failing business and then the next time still having the failing business. So this is recurrent, as well as continuous, such as a chronic illness or poverty, because a patient will have a family and poor family support, so poverty. So this is a stressor. It affects a single individual, family, also can affect a community, meaning like a disaster like tsunami, natural disaster, racial, social, or any religious persecution. And also, a stressful event can be a specific developmental event, meaning like beginning of school, leaving home, getting married, becoming a parent, failing to achieve academic results or goals, and also retiring. So for epidemiology, it's said that 2 to 8% of the general population have adjustment disorder, and women are more prone twice more than men, and mostly single women are at high risk. For adolescent, it's equal for both sex, and adolescents are more frequent to develop adjustment disorder, and it could be at any age. So common precipitating stressors in adolescent is like school problems, beginning of school, parental rejection, divorce, as well as substance abuse. As for adult, it could be a marital problem such as divorce, moving to a new environment, and a financial problem. So look at the etiology. We have the psychodynamic, which could be depending on the nature of the stressors, as well as conscious and unconscious meaning of the stressors to the patient. So a patient's pre-existing vulnerabilities, so like the age, gender, health level, psychiatric comorbids, actual or perceived support, or negative psychosocial factor, meaning like if a patient who have a comorbid such as depression, any other psychiatric illness, are more prone to have adjustment disorder, are more vulnerable. And then we have family and genetics. So correlation of reaction to stress, monozygotic twins are more prone than dizygotic twins. And then a genetic contribution to the likelihood of developing symptoms in response to a traumatic life event. Studies say that like if the patient has a poor childhood background, no support or no mother to child relationship, are more prone to get uh, adjustment disorder later. Why? Is because that they don't have the enough defense mechanism, or their defense mechanism is poor, like just now a doctor mentioned. So diagnosis according to this DSM-5 criteria. So we said here the development of emotional or behavior symptoms in response to an identifiable stressor and occurring within 3 months of the onset. So these symptoms or behavior can be abrupt distress that is out of proportion, and significant impairment in social, occupational, or other important area of function. And criteria C does not meet any criteria for other mental disorders, and symptoms does not represent a normal bereavement. And once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. So it will have in the beginning 3 months of the onset, and later, if it persists, then 6 months. It's not adjustment disorder. So we only have until 6 months. Okay. So to specifier of adjustment disorder, this would depressed mood and depression symptoms, low mood, cheerfulness, feeling of hopelessness, or are predominant, or with anxiety like nervousness, worry, jitteriness, or separation anxiety, or with mixed anxiety and depression. Combination of depression and anxiety is the predominant. And then we have with disturbance of conduct. So there's conduct disorder, and with mixed disturbance of emotions and conduct. So we have both emotion symptoms, depression and anxiety, as well as disturbance of conduct. Or unspecified, so for maladaptive reaction that are not classified as one of the specific subtype of adjustment disorder. So the other differential diagnosis, all the following: MDD, acute stress disorder, PTSD, personality disorder, like borderline personality disorder, or normal stress reaction. Could be as well brief psychotic disorder, GAD, bereavement, and substance-induced or conduct disorder. So for management, we measure based on biological, psychosocial, and spiritual. So actually, the mainstay of management in adjustment disorder is psychotherapy. That's the treatment of choice. So if not, we add on with biological, like pharmacotherapy to augment the psychosocial. So the primary modality is anti-anxiety medication like benzodiazepine, and antidepressant like SSRI. And psychosocial, which is the important part of in adjustment disorder. So interpersonal psychotherapy, problem-solving therapy, group therapy, or individual therapy as well, involving the family therapy. And we also can have cognitive behavioral therapy, and that so for CBT, we make the patient learn to recognize and change their thoughts, their negative thoughts towards the stressor. As for crisis intervention, is like trying to, like, for people who went through crisis like tsunami, like any other like natural disaster or any other adjustment in their life. We try to expose them and assist in development of enhancement of more effective coping skills and a support system. Spiritual, we advocate more values and ethics in Islam. So for adjustment disorder, the prognosis is generally good, favorable. So, but for adolescents who receive a diagnosis of adjustment disorder, later have mood disorders or substance-related disorder. So adolescents, because they develop later mood disorders, so it's generally poor. Adolescents usually require longer time to recover than adults. And as I mentioned before, comorbid diagnosis of substance abuse and personality disorder contribute to the suicide risk profile. So it's important to assess the suicide risk in adjustment disorder. Okay, I think that is all. Thank you.
Okay, thank you, presenter. Thank you, Salma. Any question to our presenter regarding adjustment disorder?
So, Doctor, I have one question, Doctor.
All right. Okay, Faris.
Is there any pharmacotherapy or medications that we can give to patient with adjustment disorder per se?
Depending on the severity of the symptoms. Basically, you can give, there are rules for antidepressant, benzodiazepine, anxiolytic. But normally it's not meant for a long term lah. Okay. More importantly is to address the stressor. Kan? What would be the main stressor which cause the patient to develop the adjustment disorder. So that is more importantly to address, kan, manage the stressor, because if you see into the diagnosis, you will expect that the symptom will improve the moment that the stressor is resolved, kan. So that is why it's called adjustment disorder, kan. So the role of medication can be given or no need, kan. Some of your patient, just by giving supportive therapy, talking therapy, they already can cope with the stressor, kan. But some of the patient, they may have more severe symptoms which warrant some help of your pharmacotherapy lah. Okay, so in children you will see they will present with the last two type of adjustment, kan. They can come with adjustment disorder with conduct disturbance or adjustment disorder with conduct and emotional disturbance, kan. So those are more frequent among child, kan, child patient. Okay, but with adult, they come to you with either depressed mode, anxious mode, or mixed type, combination of anxiety and depression. But you have to get the clear stressor lah, kan, before the development of the symptom. You manage to get there is some quite clear stressor to the presence of the symptom, kan. Alright. Lagi, any other questions?
Doctor, I have a question.
Alright, Salma.
If after the 6 months, because we said that it's within 3 months, and then we have for the patient until 6 months till the stressor will be relieved. After that, if it's more severe than that, what do we diagnose?
Then we go for the other axis 1 diagnosis lah. If let's say that patient initially presented with adjustment disorder with depressed mode, kan. So let's say if the depressive symptom persists even after the stressor is removed, then you should entertain the more more hierarchy lah, the diagnosis of major depressive disorder. Alright, because when you want to entertain adjustment, you should expect that by removing the stressor, the symptom should actually subsided, kan. So again, same with other disorder we discussed earlier, factitious, malingering, your PTSD, even adjustment disorder also more commonly occur among those patients who have underlying personality disorder, kan? Because the fact that patient had disordered personality, so of course they will have some non-adaptive coping. That's why they are more prone to develop adjustment problem. Okay, ada soalan lain lagi? Any more question? Clear dah? Penat dah? 4:36. Semua tepu dah, full. Alright, so I hope you benefit from the session that we have. Also with adjustment ni, you can see among your other patient, kan? Because later on you are going to work in medical ward, surgical ward, obstetric, gynecology. So the moment that you diagnose patient with certain illness, certain disorder, kan? So expect some psychological reaction from them because they are all human. It's common for a child patient, kan, pediatric patient. The moment you diagnose them with acute leukemia, for example, so sometimes they can end up having conduct disturbance in the ward, kan. They start to be sulking, they start to show some conduct disturbance. So because there should be some psychological reaction. The same adult patient, when you see in medical surgical ward, upon diagnosis of certain illness, do expect some adjustment disorder among your patients so that you will not forget to address and manage the psychological issues that they are having on top of the physical illness that they are diagnosed with. Okay? So jangan lupa, it's not meant for the outside patient je. It's very reliable, it's very relevant to your patient when you work in the ward later. Okay? Okay, any other question? Tak ada lah, habis dah. Okay lah, so we thank all the presenters for all the excellent presentation, and we close our class with Surah Al-As and Tasbih Kifarah. Okay, thank you everyone. Assalamualaikum
Thank you very
warahmatullahi
much, Doctor.
Okay.
Thank you, Doctor.
Okay.
Thank you, Doctor.
Thank you, Doctor.
Dia lalu tapi dia tak tutup.